Well, thank you very much, Raphael and Yehud, for this kind invitation. It's a great pleasure to talk to you about the transnasal endoscopic approach to the sphenoid. So I'm an ENT surgeon, so my job basically is to create adequate exposure for tumor removal. For this, neurosurgeon likes good visualization because they don't want to be annoyed with blood dropping on the endoscope, and they will have a clear view. What you like is room for manipulation. You want to have tactile feedback that allows you to really feel how far you can go. You feel the structure, you feel the texture. And if there's a high flow CSF leak, what you really want to have is a vascularized flap, especially in cases that need radiation therapy after resection. So this is the general goal of any approach. So, of course, we like the endoscopic approach because we have a wide field vision. This is what we generally really like. But we really need room. And in order to get room, we, in most cases, do a binostril approach with the endoscope on in the right nostril. And by elevating the endoscope cranially, we get even more room. And then it's possible to have a binostril dissection of a tumor where we have room in order to facilitate tumor removal. That's the setting in the operation theater. We stand usually on the right side of the patient, look to the monitor, and you see on the right is the neurosurgeon. This is Michel Rötlisberger in the room here, and he has now the ability to bimanually work on this tumor. You see the slide later on again. So what really annoys a neurosurgeon is when he doesn't have room and when the instrument basically are hindering manipulation. And this is the case if there's an obstacle in front in the entrance of the nose. That's the worst thing we don't want to have. If there's an obstacle in the nose, more in the back before the sphenoid sinus, it's still annoying, but it's not as bad. But what we really like to have is a wide corridor that allows bimanual manipulation without any obstacles. So in order to do so, we have to get access to the sphenoid sinus. And there are different ways to guide us to the sphenoid sinus. The easiest is basically the transnasal route, where we just get a glance into the sinus. Usually we do a transseptal approach where we are in the midline and open the rostrum and then get into the Sellar, into the sphenoid. If we need more lateral exposure, we can go through the ethmoid. And if there's a really large sphenoid sinus with a lateral recess, we see it in a case later on, we want to have a transpterygoidal approach. So let's see what important structures are there on the way, which important structure we need to be aware of in the paranasal sinuses. We need to be aware of the lamina papyracea, which is thin bony membrane of the medial orbit. We don't want to injure that during our procedures. We have the anterior ethmoidal artery, which can be free floating in some cases. If we injure the artery, this has a risk that the artery retracts into the orbit, causes bleeding, and this is not good because it rises to intraorbital pressure. We have the lateral lamella, which is a thin membrane of bone. If we manipulate there too rigidly, it can cause CSF leak. And of course, Christian mentioned it, septation of the carotid. We want to be aware of that we don't get lost inside the Sellar, but we also have to be careful in manipulating on these septations because when they are in close proximity to the carotid. Then there are the Onodi cells, which are air cells in the ethmoid, which are actually above the sphenoid sinus, usually in close proximity to the optic, and there we need to be careful, don't get lost and don't injure the optic nerve. So step by step, the approaches, transnasal approach is a left nostril, you see the septum, you see the middle turbinate. If we go more inside the nose, you see the superior turbinate. Now we push back more laterally the middle turbinate. Then we get to the superior turbinate. And between the superior turbinate and the septum, it's the natural ostium of the sphenoid sinus. You can see here, and we can look inside the sphenoid sinus. So usually this only gives us a glance into the sinus. We want to have more room. So usually what we do is a transseptal approach where, well, it's a little hard to see on this slide because of the color. We go, it's easy to explain in the video. You see there's a case of a microadenoma. This is the incision on the right side on the septum here. Then we prepare a mucoperiosteal flap. This is the rostrum. The color is a little bit odd with the beamer, I'm sorry. Then we enter the sphenoid sinus. Sometimes this bone is really thin, as in this case. Sometimes we need a Harrison punch or even a drill. Then the rostrum is removed. And once we remove the rostrum, we get access into the sphenoid sinus. And you see here the septations. They have to be removed. And now you see the tumor removal. You see how elegantly this is done. And of course, it's not always like this, but this was a tumor that was easily removable. And of course, sometimes this is not enough just to have a transseptal approach. We want to be more room laterally. This is a case of a Graves' disease, morbus Basedov, where the orbit needed to be decompressed because of the muscles that were swollen. So what I do here, it's a left nostril. I open the maxillary sinus because this is an important landmark. This is the maxillary sinus. Then the ethmoid is opened. And once the ethmoid is opened, then I can enter the sphenoid sinus. The sphenoid, I enter at the level of the floor of the orbit. I go medially so I don't injure any structures. And now the lamina purpurea is removed. Maxillary sinus, lamina purpurea, periorbit. You see the posterior ethmoidal artery, anterior ethmoidal artery. You see the carotid and you see the optic. And now you can see how lateral we can access the sphenoid sinus if needed. Of course, in this case, the periorbit was removed, so the orbital fat could get into the ethmoidal sinus, so the orbit was decompressed. But this case was only shown to illustrate a transethmoidal approach. And of course, we can combine a transseptal approach with a transethmoidal approach when we need adequate exposure. And in cases when the sphenoid is really well pneumatized, that means a lateral recess, which is air cells or air lateral to the V2, then we have to choose a transpterygoidal access to the sphenoid. Usually in these cases, we remove part of the inferior turbinate. B, the middle turbinate, you can see. We have to get access to the posterior wall of the maxillary sinus, as you see in C, then control the sphenopalatine artery, drill the pterygoid base or the pterygoid wedge, and then get access to the lateral recess. This is a case illustrating this. You see the V2, you see the Vidian nerve, you see meningoencephalocele on the right, and you see the surgical video step by step. First step, it was necessary to enter the sphenoid sinus where we confirmed the CSF leak. You see a Sellar, the clivus, the paraclival carotid. You see there's some CSF with the fluorescence visualized. Then the next step is actually to do a large enterostomy of the maxillary sinus. This is done here, that we actually can visualize the back of the maxillary sinus, which is seen here. And you see now control of the sphenopalatine artery. These are 3 branches which are dissected and visualized. Now these branches then are cauterized. And now we get a glance of the lateral recess of the sphenoid sinus. Then drilling needs to be done of the pterygoid wedge, which is in the way, actually, so that we don't have enough lateral recess. And now we see the V2, the meningoencephalocele, and the Vidian nerve. And once this is removed, you see the defect in the middle cranial fossa, which then was closed, watertight in a multi-layer fashion. High flow leak was not the case in the case I just showed you, but it's a big problem when we actually are entering, for instance, like the third ventricle in a craniopharyngioma, and there we really want to have a vascularized pedicle flap because this allows watertight closure in a multi-layer fashion. And this flap is basically nourished by the sphenopalatine artery, the artery you just saw, which we had to cut. And in these cases, you go above the choana, take a cut, go down, and you can go as much anterior as needed. And superiorly, your landmark is the ostium of the sphenoid sinus. And then you don't want to go too high in the beginning because there's olfactory epithelia, and then you can go up again and really have a nice vascularized flap. This is just to illustrate. This was a case with a CSF leak that caused meningitis, and you see it's a leak in the clivus. I really like the Colorado needle to do the cuts, as I showed you in the sketch before. Then the flap is elevated and pushed back in the nasopharynx. And then next, of course, the sphenoid is adequately opened, and you see the defect. You can see the basilar artery. This is the defect visualized in the clivus. And then this defect is closed in a multi-layer fashion with fat. Please note that all the mucosa here had to be removed, because you don't want to put this flap on mucosa, because this can cause formation of mucocele. And when you put the flap into place, as you see later on, you have to make sure that the mucosal side is outside, once again, to avoid formation of mucocele. And now you see this flap is pedicled on the sphenopalatine artery. It's a very robust flap here with the pedicle inside here. It can be brought onto the defect, and it nicely sticks on the bare bone, and this now allows adequate closure of this leak. And we always like to put some fat on top of this so that all the edges are nicely stuck, and the chances of a leak are very low. Christian mentioned it. Another problem is the sphenoid sinus. What we really like is a nice pneumatization and in a Sellar or the post-Sellar pneumatization. But of course, what's really difficult is when you have a congel type, as you see in Thea, where we don't have the landmarks. So what we really like to have is this situation where we have a nice pneumatization. This was a case of a young woman with a low-grade glioma. And you see the sketch that already Christian explained. In this case, this was actually the case you saw Michel operating on. The planum, the tuberculum, and the Sellar all had to be exposed and open to get adequate access to see the pituitary, the stalk here, and to see the optic. And for this, you really want to have adequate exposure. You want to have the landmarks before you enter the dura, before you open the dura. But of course, sometimes the pneumatization is so good that we have cases like this. This was a macroadenoma. Christian might remember this case. It's some time ago. But in this case, the carotid was dehiscence on both sides. And when you actually look close, you see the blood pulsating in the cavernous carotid. And the carotid is only covered by mucosa because it's so nicely pneumatized. So there you have to be careful because you don't want to injure the carotid just with the suction. What's really the challenge in the approaches is if the sphenoid is not pneumatized. And this here on the right, you see pneumatization of the sphenoid start at birth, and then it takes about until 12 years of age until this pneumatization reaches the adult size. But there are some conditions which have not good pneumatization of the sphenoid. For instance, mucociliary problems like cystic fibrosis. And this is a case here from the Children's Hospital where the patient had a mucoviscidosis and very bad pneumatization. This is a 9-year-old girl, and you can see on the left there's no air cell inside the sphenoid. We first thought it's the craniopharyngioma, but then it was a teratoma. But this illustrates the approach here. It's a transseptal approach where we go now to the right nostril. We prepare everything to rise a Haddad flap. I don't show you this, you have already seen. Up to here, everything is normal. You see the rostrum. And usually when we open the rostrum, we really expect to have a nice air-filled cavity. This is not the case. You just see bony, you just see bone, is fatty bone marrow. There is absolutely no landmark. And so a lot of drilling is needed in order to get to the cortical bone at the end of this bony bone, of this fatty bone marrow. And you can see it's not as in the case before, where we nicely see the optic, the carotid. We basically see nothing. We have to use IGS and stay in the midline. But then at the back, there is thick cortical bone, so the drill sounds differently. And once this is removed with the drill and the Carrison punch, you see here the picture from tumor removal. And now you see the surgery has taken out most of the tumor. So this is the challenges we face in a situation where the sphenoid is not pneumatized. I would like to close by